All right, so as Lily just stated, our 9th VT Reach session is going to be highlighting occupational therapy with Victoria Priganc, Jennifer Elsinger, Nikki Haako, and Aimil Parmelee. And so we're really excited to have everyone here tonight. And as you think of questions for any of these speakers, feel free to throw them in the chat. Lily and I will get to address those during the Q&A sessions. And so we'll start with Victoria. And we actually just have a quote here. Man, through the use of his hands, as they are energized by mind and will, can influence the state of his own health, by Mary Riley. Oh, Victoria, I think you're muted.
Sorry about that. If you want to actually go back to that first slide that you just talked about real quickly, this quote here is really probably the quote that is the most cited in our field, in the field of occupational therapy. And this quote is by Mary Riley, who was born in like the early 1900s. She's considered one of the first OTs. And in the, I think it was like in the 50s or 60s, she was giving her Sligo lecture, and she said this sentence in her Sligo lecture. And this sentence has since kind of carried on and been kind of like the backbone when people are thinking about the occupational therapy profession, because what it really talks about is this entire idea that if people are able to really do purposeful activity that they want to do, regardless of what's going on with that individual, but if they can actually find a way, and if we can help them find that way to do what it is that they want to do by identifying the barriers, whether it's a physical barrier, whether it's a cognitive barrier, whether it's an emotional barrier, whether it's an economical barrier, that people can influence their own health if they are engaged in life the way they want to be engaged. So when this quote actually was put into the slides, I thought that's perfect, because it really is a great way to start kind of talking about the profession. And there's 4 of us that are going to be talking tonight, and you're going to hear differences from all 4 of us in terms of even how we got into the profession, how we moved through the profession, what we're doing right now. But at the crux of everything is this whole idea of engagement the way you want to be engaged. So I really liked starting with that particular quote. So thank you to whoever put that in there. I do appreciate that. So, and we can go to the next slide then. And so this is me. So I'm an occupational therapist. So the OTR/L, those are the credentials for an OT, and I'm licensed in the state of Vermont. I'm also a certified hand therapist, that's a CHT, and a certified lymphedema therapist, that's a CLT. And then I do have my PhD as well. So those are kind of what all the acronyms mean, because you guys are going to see more of those acronyms as we go through tonight. And next slide. So one of the questions that I do get asked a lot is, how did I get into occupational therapy? And I don't have a good story at all. And I should probably try to like make one up, but I haven't so far. So I'll tell you kind of my story, which is not really all that exciting. But I knew that I wanted to get into the healthcare field. I knew that I really wanted to help people. But I also knew that I live in my life is not black and white. I have a very creative side. I have a very putsy side to me. I like to tinker. I like to do things. And I kind of like the gray zone. So as I was exploring different professions, I kind of just stumbled into occupational therapy. And so I did receive my Bachelor's of Science in Occupational Therapy, because when I took it, it was still a bachelor's degree. And I got that at the University of Wisconsin in Milwaukee. And then when I graduated, I was trying to move out west because I really wanted to learn how to ski. I grew up in an area where nobody skied. So I applied to all sorts of positions out west, and then I applied to one in Vermont. And I was flown out for that interview and absolutely fell in love with Vermont. So I took that position and ended up heading out east. And then when I was here in Vermont was when I decided to get my master's in movement science and rehab at the University of Vermont. And the master's degree that I got was a research master's. So I had to do research, but I also had to teach a class. So I taught a class in hand rehab because that's where I was practicing at the time. at UVM, and I had a blast. It was so much fun. And I thought, wow, maybe I should think about going into education. So at that point, I decided to try to see if I could land a position in the academic setting, just to test it out for a year or two, see what I thought of it. So I once again fired all sorts of applications out west, and then one out east, and I ended up going further east. I ended up going to the University of New England in Maine, and that's where I started teaching. And after teaching for about a year, I was really loving it. So that's when I decided I better go back for my doctorate, because I knew that that's what I was going to need to be able to continue in the education field. So that's kind of my educational path and my educational background in terms of how I got to where I'm at this point. Next slide. When it comes to kind of my path, my professional career, so every student that goes through an OT program has to do level 2 fieldwork. And everybody, I think today will be talking a little bit about their level 2 fieldwork. It's kind of your first time that you're getting into the profession. It's the first time that you're actually working in the profession, but you're working under an OT. So they're signing off on all your notes, they're looking at all your treatment plans and all that kind of stuff. And you do that for a minimum of 6 months before you can even graduate from OT school. So I did one of my level 2 placements at the Mayo Clinic in Rochester, Minnesota. And this was still when I was getting my bachelor's degree. And I absolutely fell in love with the hand rehab portion of our profession. I was working with, at that point, some of the top hand surgeons in the US, probably even in the world. And I was so intrigued by how just a small little injury that happens to the hand can really impact people's function and people's ability to do what they want to do. So when I graduated, the position that I landed here in Vermont was in the hand rehab center. And that's where I started my clinical career. And then over the years, I did a variety of other things. I did some work in home health. I did some work with high-risk dads, kind of helping them readjust to how they can be better integrated in their children's lives, to see how that impacts the health and well-being of children. So I did some of that work as well. But for the last decade, I've really been in the academic world and spending some time doing some consulting, but really developing programs, doing different scholarship projects and things along those lines. I recently did get my executive certification in home modifications from the University of Southern California, and I'm starting to move into that direction with some clinical time, not a lot because at the university, my time's pretty booked, but a little bit of clinical time in that area of practice, which I think is going to be great fun, and linking in some scholarship projects with that as well. And that's just getting started. So that's a little bit about kind of where I started and where I am at this point. And so my primary responsibilities right now is I am the founding program director for the occupational therapy program here at the University of Vermont. And what's exciting is that this is the first OT program in Vermont. And I've been told by people that a lot of clinicians, a lot of people in the state have wanted an OT program here for, I've been told 20 years, I've been told 30 years. So I don't know what the actual number is, but what I do know is that the community of not only people at UVM, but the clinicians in the entire state are so supportive of this program. So we're very excited to announce that we have started accepting applications for our very first cohort. Our very first cohort will start in fall of 2022, and we're in the process of finalizing the curriculum, just finalizing a lot of the policies, procedures, getting the labs ready, and setting up different opportunities for our students to not only do their clinical work, but to also get these experiential learning opportunities with various clinicians in the community as well. And that's my primary role at this point from a professional perspective. So when it comes to my work-life integration, what I've learned about myself is I really do love the academic setting. I think for me, I just love the constant exploration that happens. And I love working with the students. I love the energy that the students bring. I love the questions that the students bring. I love it when some students come in and say, I know exactly where I want to go with my, with my OT career. And then I love it when I have students that say, I have no clue where I want to go with my OT career. Every aspect about it for me is just so fun. So that makes me realize I've landed in the right spot where I'm supposed to be. When I'm not working, I love to Nordic ski. I love to be on my paddleboard, hike, bike. And then one of the pros for us with the pandemic was my family and I, we really got into ethnic cooking. And for a while there, when we were on lockdown, every night we would just kind of like throw a dart, pick another country and then explore that country. And then just my daughter and I would cook for like 2 hours and make this ethnic meal. And then the boys would clean up, which was great. So, and we started carrying some of that over. We're certainly not doing that every night anymore, but that was a very fun thing that we've done and have continued on with as well. So, and that's a little bit about me. I saw there was one question that popped up real fast in terms of the program, if it's a master's or a doctorate level. It's coming in as an entry-level doctorate. And other questions that pop in later, we do have a Q&A session later. So that's me.
Thank you so much, Victoria. And so now we'll move on to Jennifer and let her talk about her inspiration into medicine.
So I always knew I was going to go into medicine. My mom worked in the emergency department in Springfield. She was an X-ray tech and she worked second shift. So we didn't see her much, but my dad would take my sister and me in once a month or so to try to have dinner. And the whole environment was really fascinating to me. So with that, I really didn't know what direction. In fact, I have to tell you, I did not know what occupational therapy was until I was in college. I started in pre-med and just realized and learning about the future and of what my future would look like and how much time dedicated to school. I wasn't exactly sure what I wanted to do. So I figured I'd start doing some research and I fell upon occupational therapy. I was thinking about physical therapy, but I went to the University of New Hampshire and occupational therapy was offered and I was able to shadow and transferred in my sophomore year, which I was really lucky to be able to get into so quickly. And so I, again, graduated way long time ago when it was only a bachelor's degree, which, down the road, I think, I think about doing a doctorate of some sort, but right now with my CHT, I feel like I'm where I'm supposed to be because I definitely love what I do every day. So after I graduated, I thought I was going into pediatrics. And so I did a lot of my affiliations, like Victoria said. Mine was a 4-year program. In the 5th year, I did 4 3-month affiliations, one in a school system, one in, we had to do a psych at the time, which was great. That was my minor. And then I did a physical dysfunction one or a orthopedic one at UConn. And then my last one was a specialty area, and I chose neonatal intensive care, where I worked a lot with feeding babies and working with the parents. And I realized with children, especially small children, you're going to work more with the parents than you are the kids. And I learned about myself. I learned, wow, did some sensory integration kinds of things. And I got really attached to these kids. So I'm like, I'm not sure. There was a lot of things, but I love the fact that I could be exposed before I actually jumped in. My first job, I jumped into the right position. I worked at a rehab center. I worked on the inpatient unit and learned the whole foundation of even what I do today. At that point, I was able to transition after 3 years of working. I actually covered somebody's maternity leave in the outpatient department where I started with the shoulder. And I worked alongside of a CHT, which I loved what she was doing. I used to watch her. She was studying for her exam. She actually wasn't a CHT. When I started working with her, she eventually passed the exam, which I learned about later. And I realized that's the path that I wanted to go. So I sort of kind of worked my way down. And then at that point, after 3 years, I knew that the area that I was working in, there was a lot of hand surgeons, but at the time they were pretty much linked with their therapists. Not that I couldn't join in, but I kind of wanted to explore a little bit. I ended up, well, I'm from Massachusetts. I kind of went in Connecticut and then North Carolina for a while, back in Massachusetts. So I went north a little bit, ended up in Vermont because it had what I was looking for. I did not have my CHT at the time, but I could start in a program working with injured employees and learning more about hands. I did work site evals. I did looking at ergonomics, and I treated a lot of subacute tendonitis types of injuries. And also part-time with that, I was able to kind of work my way into the hand clinic, which was a lot of post-operative, more acute cases, which at that time was new to me. So here I am, almost 23 years later, fast forward, definitely got my CHT when I transitioned full-time into the hand therapy world. And I still actually, one of the surgeons that I started with, he's still there. And it's been just a great fit for me and my family. My days right now we work directly with the hand surgeons, which was a big, that's what I was looking for. It's really great for education. I treat anything from fractures, well, all kinds of things, tendon injuries, sometimes multi-trauma comes into the clinic, but it's definitely on the outpatient level. So there's, you form relationships with patients, which I really like. It's very collaborative with physicians assistants, and your peers. We're always kind of, hey, will you come look at this? We do a lot of splinting, which is, like Victoria said, very much a creative part of what we do. I mean, we can see and make up to anywhere from 10 plus splints a day, from a finger to a big posterior elbow. We do immobilization splinting, so for protection. We also do splints for stiff joints. So we have all kinds of outriggers and rubber bands, and every day is a different day, which is great because yeah, it's really exciting, and you make a difference. Yeah, I do have some administrative time where I have to go and hide because I prefer to be in the clinic and I prefer to treat patients. So I kind of land there more times than not and not get so much of my administrative stuff done. I also volunteer on the hand therapy certification committee, the exam committee, which has been really cool over the years to see that exam kind of change over the years. Right now, to become a CHT, it is 4,000 hours of time in hand therapy after you graduate, and then 3 years of experience, and then you sit for an exam to get that certification. It's definitely a specialty area of OT, but it's growing for sure. So yeah, I have 3 kids, a dog. I love to run and do outdoors things, hike and bike, and I'm going to try some backcountry skiing this winter. I'm a little nervous sometimes because I see a lot of injuries, especially as with the ice and snow coming. It's our busiest time, sadly. But I'm gonna step out and try it.
Thank you so much. It was great to hear from you. And next we'll be hearing from Nikki.
Hi, my name is Nikki Haako, and I'm an occupational therapist at the University of Vermont Medical Center in the outpatient setting. And I graduated from high school in 1990. And at that time I was up in Montreal, and I had no idea what I wanted to do, not a clue. So if any of you are worried, that's normal. But what I did know was I worked with the counselors at school or someone, but they said, find out what you do like. And the things that I liked, I knew I wanted to work with people. Desk jobs were not my thing. I was very compassionate and I liked to try and problem solve things. And I just wanted to stay in the sciences. The sciences were important to me. So what I ended up doing was going into a psychology degree. I thought that maybe that would be a good fit for me, but at McGill, it's a very large university, and I sat in my intro to psych class with almost 1,000 students, and I realized quickly, not all of us were going to be clinical psychologists, so I thought I'd figure out what I wanted to be when I grew up. So I started doing a lot of volunteer work in different areas. I was big into sports when I was growing up, so I did a lot of volunteer work in sports camps with developmentally disabled kids, with at-risk kids, normal development kids, and everything that I could try and involve myself in to try and figure out where I wanted to be. And then I started shadowing people in OT clinics, and that was when I realized that OT was really what was going to be best for me. So I graduated in 1996 from McGill University with a bachelor's, because it was a bachelor's back in the 1900s, for occupational therapy. When I graduated from McGill in occupational therapy, I knew I didn't want to stay in Montreal because it gets really cold up there. Yet here I am in Vermont. So I wanted to see the world and I wanted to explore different places. And at that time, they were sending huge sign-on bonuses. So a friend of mine and I took a risk and we went to Florida, where I got a job in an acute and a subacute setting. And I loved what I was doing. It was really a lot of fun. At some point, there was a shift where I felt like, well, now what? If they're in acute care, there seemed to be this gray zone in between the acute and the subacute setting where the therapy was the most interesting to me. And I transitioned to work at the rehab therapy hospital in Pensacola, Florida, and that was where I found my passion. So it took me probably 5 years to figure it out, but at that time I figured out that I loved neuro rehab and that was where I wanted to be. So I lived in Florida for a few years, met my husband and got married. He was in the military. We moved to California. The thing that's great with occupational therapy is it's very transportable. So you kind of know what you're doing and you know where you can look, and they're always looking for therapists, which was wonderful. So we moved to California and I got a job in an outpatient neurological setting and just kept learning and going. And there's skills out there that I was really excited to learn about. There was this thing called, back in the 1900s, the neurodevelopmental techniques, which were a big push. And I did a lot of training with the people that created that program and just kept digging in deeper and finding my passion. We then started having kids. My husband is from New Hampshire, and as I said, I'm from Montreal, so we wanted to be closer to the family. So we moved to Connecticut. And when we got to Connecticut, I knew I wanted to be home with the kids more, so I worked part-time. And I was able to find part-time jobs in skilled nursing facilities, in outpatient settings, in home health, and just kind of keep building my skills, working part-time, but also being home with the kids. And then at one point, we wanted to get closer to my parents who were having medical issues. So we moved to Vermont, and that has been the absolute best move that I've ever made. Even though I ran away from Montreal because of the cold, here I am in Vermont, embracing the cold. And I fell into this job and I absolutely love it. When we moved here, I started on an inpatient neuro setting. So the neuro rehab. So after people leave the hospital for a medical event, when they're medically stable, after a stroke, a head injury, a spinal cord injury, any kind of event that might have altered their life, they will go to rehab settings so they get a lot of therapy. And that was where I just kind of dug in and thrived. And then after a while in that, an opportunity opened up as a clinical lead in the outpatient setting. And I switched to that, and that's where I found my passion. In the outpatient setting that we're in now, there was a big drive for interventions or treatments that had a lot of visual challenges. So I started taking courses on that and realized that that was something that I also loved, and ended up doing a college degree for a vision certification. And now I'm working towards my doctorate in occupational therapy. So I'm about halfway. But as I said, I'm a clinical lead at the neuro outpatient center that I'm in. I spend 75% of my day working with patients and 25% in clinical care. So I work from 8 to 4:30. Like I said, 75% with patients. So I see about 5 or 6 patients a day. And then the other couple of hours I'll work on program development. We try and keep up to date on all the new research that's coming out. So it'll be wonderful having the University of Vermont here with an OT program, because we'll be able to collaborate with them and try and keep ourselves at the front end of the research. I mentor other occupational therapists. I took in a lot of classes lately on the vision stuff and then other things, and we just keep mentoring each other so that we can keep getting better as clinicians. And there are tons of meetings. There are always meetings, but that is what the bulk of my day looks like. When I'm not working, I have 3 children and a dog as well, and we love to play outside. We have a few sailboats, we have kayaks and paddleboards, and we love to ski, cross country, downhill, and kind of like Jen, we're starting to AT ski this winter, and I'm really excited about that. The one bad thing about working in healthcare is you see the bad of everything, and my poor children for the longest time weren't able to do anything. If there were wheels between them and the ground, they had to wear a helmet. But after a little while, I was able to kind of slow down and give them space, and they're all pretty well adjusted. But that is my occupational therapy journey.
Thank you so much. And now we'll hear from our 4th speaker, Aimil, and your inspiration into medicine.
Thanks so much for the introduction. So occupational therapy actually is a second career for me. I'm very fortunate that I grew up in a household with a mother who's an occupational therapist. So I can speak to Victoria's point that growing up in central Vermont, I knew that we did not have an OT program here and that we'd benefit from it back when I was a child. So it's been around for a few decades. I watched my mom navigate multiple different careers. She never seemed to be bored. She was always filled with passion. So when after I graduated from undergraduate, I really felt like my original path was not going to be a great path for me. I did not like sitting at a desk. My original plan actually was to go to law school, and I felt like if I don't like sitting at a desk now, I think being a lawyer is probably a really terrible idea. So I looked at a bunch of different things, social work, physical therapy, occupational therapy, and I just kind of kept thinking about how happy my mom was. She was able to be creative. She worked early intervention through hospice in every sort of possible setting in her career. So that's sort of how I ended up in occupational therapy. So my undergraduate I was a business major with a mathematics minor and a 1 class shy of a poli-sci political science second minor. And the goal was to go to law school. When I decided not to do that, I'd already moved to Maine. And I actually ended up at the University of Southern Maine for graduate school. So when I went to OT school, it was an entry-level master's. I was really very fortunate. I had attended a very small program, so there were 12 students in my graduating class. And it was a really the sky's the limit sort of a program. So anything I wanted to do, I had great faculty support to try it out. While I was there, one of my classmates and I designed a backpack awareness program for adolescents, so like 6th, 7th, 8th graders. And we paired with LL Bean, who had already paired with the OT's national organization, AOTA. And their lead backpack designer came out with us when we presented. They donated backpacks for us. And it was really interesting to be able to speak with someone about the research that we'd done and how it overlapped sort of in real life, I like to say. And we ended up being able to present that program we designed at national conference my second year. So it was really the support of the faculty in that really small program. So I felt pretty fortunate. So after graduation, I landed in a neuro rehab center in Southern Maine. So, I forgot to talk about my 2 field work. So I did 2 rotations, one in central Vermont at a hand clinic, an outpatient orthopedic center. And I did not find the same inspiration that Jen and Victoria have spoken about. I found it very interesting and I liked connecting with patients. My second rotation was an inpatient psychiatric adolescent unit. And I found that really fascinating, being able to really connect with young people and their families as they were really struggling. So that sort of led me to my first job, which was this neuro rehab center. We don't have a similar program here in Vermont. It was Maine does their brain injury treatment a little bit different. This was a subacute rehab setting, and people could be there for a really long time. So I had the same patients I saw 5 days a week that lived, at the rehab center for months, and some of them for years. I worked with them from very low ranchos level. So, maybe they weren't able, not able to connect really with people, to from that level to returning to being able to feed themselves and participate in ADLs, and returning to doing physical transfers and walking. It was really an incredible place to work. I worked with a lot of young therapists. We had a lot of energy. There was generally a lot of shenanigans that happened. It was wonderful. A lot of people use their sense of humor to get through. So I really actually enjoyed that. That's really where I found my passion for neuro. So like Nikki, that's really my absolute passion, is treating neuro patients. After I was there for about 2.5 years, we wanted to move back to Vermont. So my spouse and I both grew up here in Vermont, and we wanted to be closer to family. So I took a job with Central Vermont Home Health and Hospice about 10 years ago, the month before Irene came, which was for those of you who don't know, is a tropical storm that came through Vermont the end of August 2011, and completely decimated my area that I was newly assigned to. And so I learned through that sort of what communities do in disaster response. We had hospice patients that you couldn't get to. We had home care patients whose homes were no longer habitable, or had gone down a river. So I learned very quickly what sort of crisis response is as an occupational therapist, and how to support your community through a disaster. It was really a very interesting time to practice. And that's something that's kind of always stuck with me. You learn your community's resources really quickly in Vermont, because we have really strong communities. So every town sort of has their own way in which they care for their people that are recovering. And I found that absolutely wonderful. I like the autonomy of being in home health. I kind of set my own schedule. I saw my own patients, and I really liked being able to treat patients and their families, giving families education on what my patients were going through and how to support them. And it was a really wonderful opportunity to be creative, because no house is the same, no person is the same. So it was a lot of building, a lot of creativity. And after a few years, a position came open at Central Vermont Medical Center, and when I had neurological patients, I was discharging them to outpatient up to UVM, which is about an hour drive for most of my patients. And CVMC had recently hired in a neurological PT. So I went and helped design the neuro outpatient program at CVMC, and kind of got that up and running. And then ended up 2 years later back at home health. I just really missed being able to drive around and see my patients. So that was during the pandemic, that became really difficult. I was seeing COVID positive patients at home. Home health has always carried a larger COVID positive population than our acute care hospitals and rehab centers. Most people who have COVID are treated in the community. And so during that summer, I was treating COVID positive patients, and I transitioned into a new role, which was newly developed for our agency, called a complex care coordinator. So what I do now is I actually I support our case managers who are in the field with coordinating community-based resources, different funding programs, and different community supports. It's been really interesting working that job through the pandemic. So I work primarily with our local area on agents, local agency on aging, our designated agency, which is Washington County Mental Health, primary care, the hospital, ER staff, and our local emergency response teams. I also do a significant amount of work with our homeless population that are in general assistance housing, housed in the hotels right now. It's been a really, really interesting time to take on a completely new job and a completely new position at an agency I've been at for a long time. So I tell people now that I sort of do occupational therapy for the community. I just connect resources and think about different ways to approach some of the bigger problems. So I'm now on a couple of meetings or in a couple of work groups that are really looking at how do we in our state manage some of these gaps that we have in our healthcare system. What does that look like, and what are other places doing differently and maybe better than we're doing here, and how can we model our programs after that, or how can we create a model that maybe works better for our population? So that's my current work. So next slide. So my work-life integration. So this is the first time in my OT career that I have a really hard boundary about my time off, because a lot of my work now is like, you know, crisis management, working with really tender populations, people that are really struggling. And I found for me, I really need to have time where I'm not thinking about work and not doing work. So during the week, I work Monday through Friday, 8 to 5. I take calls from the ER case management at home up until 7 o'clock. Sometimes my day starts, if there's something that happened in the ER overnight, sometimes my day starts at 6:30, 7 o'clock with, you know, whatever the kind of current crisis situation is. So that's sort of my work day. It's a lot of meetings. I attend meetings for ER high utilizers of the hospital, so people that get rehospitalized within 30 days of discharge. I attend a routine meeting, our biweekly meeting on homelessness. I'm on a local intra-agency team. I'm a clinician that sits on that team that looks at people who have struggled with housing and typically have some sort of medical involvement, and looking at what other supports or what other programs could we put in place for them to sort of stabilize their social situation. I check in with our clinical team every morning. I go to hospice IDT. So I spend a lot of time in meetings. I do some field visits. I have a special certification in the assessment of motor and process skills. So if there's folks we need with that assessment, I will go out in the field and do some visits and provide that assessment. So the other outside of work, I am on the Vermont OT Occupational Therapy Association board. I am the Central Vermont rep, and then I am the treasurer of a local nonprofit primary care that just launched, called All Brains Belong, which is a neurodiversity affirming primary care practice in Montpelier. So that is sort of still professional, but I find that more relaxing. And then outside of that, I really love to be outdoors. We live in Central Vermont, in the middle of like beautiful farm country. So I am outside with my kids a lot. We cross-country ski in the winter and snowshoe and hike in the summer and have gardens and go on adventures. My kids are still pretty young. So, you know, sometimes even just a walk around the yard's a really big adventure. So that's sort of what we do.
All right, thank you so much for everyone for sharing. And so now we're going to move on to the Q&A portion. And so I'm going to bring everyone into spotlight. so that all of you will be up to discuss. And I had a question just to start off. And we all know, so COVID's greatly impacted the majority of healthcare jobs. And we hear a lot about how there's these healthcare shortages and not enough workers. And so I wanted to know how COVID's really impacted the OT field and if there is a shortage of OT or occupational therapists in general. And anyone can answer this.
So I'll take the first sort of leap at that. I would say yes. We've been down since I left the field a year ago. We've been kind of chronically down in OT since I left. We've had a couple of travelers, we've had a couple of people that have started short term, and then both from out of state, both decided they wanted to return home to be closer to family. I think once people realized the pandemic was going to be more than a couple of months long, sort of shifted everyone's perspective. But yeah, we're both here and the local nursing homes in our area are pretty much always looking for an OT.
I can speak to our outpatient setting, the neuro outpatient setting. When the pandemic started, we had to shut our clinic because it was considered non-essential. And the only people that were coming in were people who had had strokes and were acute, very acute. So it was really recent to when they'd had their stroke. And we were down on staff, but then as we were able to open up, we did, but we have lost some clinicians as well. So we are down staff and we're working harder. And interestingly, our site has opened up a resource for post-COVID interventions. So people who have had COVID and end up with symptoms like breathlessness or brain fog or exertional fatigue, they're coming in to see us now. So we're down staff and we're up on referrals. The other thing that did happen is because everybody was shut down and everybody stayed home, a lot of vulnerable people got very weak and more people fell, more people had comorbidities, and people are coming back to us much more sick and much more affected than they would have been before.
And I can speak to the outpatient and the hand world. We stayed open. I actually worked by myself. There's 9 of us now. I worked 3 days a week and just treated acute fractures, people coming out of cast that needed protection, splinting, and then exercise programs but it was trauma or fractures. Interestingly, we have recently hired in the last year and a half 3 new full-time hand therapists. And like Nikki said, I think people let things go. Arthritis conditions seem to be more severe. People have just kind of, with elective surgeries, put things off. So we're seeing more of that influx. The surgeons with the operating rooms, one had to close. So OR time is really hard, which affects our caseload as well. So at the university, at UVM right now, that's a factor of our caseload as well.
Okay, thank you. We have a question in the chat that says, do you have to have an OT bachelor's degree? They say, for example, they're a bio major, and does that set them up for a path in occupational therapy?
Yes, you cannot actually get a bachelor's degree anymore in occupational therapy. So there are a handful of programs around the country where you can enter into a program as a freshman. Our program here at UVM is not set up with that path at this time. I'm actually kind of hoping that's a future path we can have. But right now, our program, as are most programs, is set up where you have to have a bachelor's degree to then enter into the program. And a bachelor's degree in biology does set you up very well for that.
Thank you. I had a question. A few of you had mentioned the creative aspect of occupational therapy, and I'd love if any of you could elaborate on that. I thought it was really interesting how you talked about how making a splint, for example, is a creative process.
Yeah, I can definitely speak to that. At some doctors at this point, sort of, we have some leeway of they say splint or eval and treat. So they leave a lot up to us, knowing that we've seen a lot of cases come by, and in talking to the patient, sometimes what they do for work, what they want to use a splint for, skiing, or if they're in construction, depending on their injury, it's common practice to splint above and below fracture site or of joints to kind of immobilize. But the whole trend these days is early motion. So we splint really just what is needed, and based on what they do every day, and the patient is absolutely involved in our team, because if you make this big splint for them and they're like, oh my God, I can't wear this. We really explain to them their options. And together we come up and we create a splint that would protect their injury and that they would wear. And we try to make it comfortable. And a lot of times they're thrilled because they're coming out of casts and going into a splint that's removable, and they can take showers without it. They can clean the splint. And during COVID, we did a lot of splinting versus casting. They would go into a splint because the fact that they could be cleaned and removed for hand washing and things like that. But yeah, there's a huge creative side, especially if somebody comes in, not just for protection, but if they come in and they're really stiff. There's all kinds of outriggers and mobilization splints to gain just a normal fist. Some people are contracted and, have a lot of difficulty just grasping things. So yeah, there's a lot of options. There's also prefabricated splints that people say, oh, I looked on the internet and I found, various types of splints. What do you recommend? And again, that's a whole nother discussion of splinting. But yeah, and even in exercise programs, really using the patient and what their goals are, what they want for their outcome. You can create exercise programs, splinting, all geared toward that particular patient and injury.
I think my favorite part of OT is that we are a hybrid between the creative brain and the science brain, and no two people are alike. Even if somebody had the same stroke in the same area in the same way that it affects somebody else, it doesn't affect their life the same way. So you have to figure out what you're going to do with this person to make them succeed. And like Jen was saying, if the person isn't invested in what you're doing, they're not going to do it. You can tell them as many times as you want how important something is, but they won't do it. So you have to figure out how to creatively encourage them to do. You have to figure out what they want to do, and then figure out a creative way to implement something that will help them get there, whether it's splinting, adaptive equipment, activity modification, whatever they need to be able to do the things that they want to do. Because ultimately, occupational therapy is helping people get back to the occupations of their life. What do they want to do and how can they do it? And then you just have to use so much creativity to figure it out. My husband is an engineer, and I say I'm the gray in his black and white world because he's so linear and I am not.
So I think I'll, just to add on to that, that was, I think, always my favorite part of home health, because if you're trying to figure out how to get someone to, who's new to a walker, maybe get their cup of coffee from the kitchen to the table, that's going to look different for every person's kitchen setup. And I always used to tell patients, oh, well, let's look in inventory, which meant let's look in your kitchen cabinets and see what you already own, and let me see if I can figure out a way to solve your problem with what you have. So, like a Pyrex measuring cup with the glass handle fits really nicely in a walker basket, makes a great cup holder, so it was just, being able to think of little things like that, or look at something. I use tiny zip ties all the time to make things more accessible for pinch and grasp, so people can undo zippers. I worked with a coda who really could. I used to tell people she could probably design a rocket ship out of things that she bought at the dollar store. So I learned a lot of tips and tricks from her, and it's just really fun to be able to build stuff. So that's.
And just kind of bringing in, how this is integrated into the program that's happening at UVM. OT really is that blend of art and science. And I think that's part of what probably drew all of us into this field, is there is that creative gray zone, which is super fun. And in the program, we have these 2 design classes, which I'm hoping I get to teach one of them because they're so fun. And what you're really doing is you're helping the students really break down activities step by step by step. What's really all involved? Okay, what is it that the person really wants to do? How creative can you get with what they have, like people have said, in their home, or designing something that works for where their interests really lie. And one of my favorite assignments when I do get to teach these types of classes is I'll sometimes start class and I'll tell everybody, okay, grab one thing out of your backpack, just anything. And I won't tell them what they're doing. And then I'll say, okay, count off by 5 or whatever. And then get into groups, 1s, 2s, 3s, 4s, and they all have to bring their item and they have to build something. But they have to build something well enough that we, as the rest of the class, can understand what it is that they're building, as just a way for them to start thinking in that gray zone, because a lot of people struggle in the gray zone, right? But that's kind of where so many of these great ideas come from. So we very much in this program feel strongly about that creative, innovative type of aspect to the profession. And we have courses designed specifically to help students kind of work in that area.
Wow, thank you so much. That's really incredible to hear about. I wouldn't have expected a field like that you've described to be so creative, but that does sound incredibly fascinating. I also had a question that I had been thinking about as you all were speaking. And I was wondering what the main differences between physical therapy and occupational therapy are, which I'm sure you're probably asked a lot because there clearly is a difference.
You guys want me to take this one, or Aimil, you want to?
I'll go quickly. So I use humor a lot in what I do. So when, my grumpy old Vermonter is like, I already saw physical therapy. And I'm like, oh, I'm OT, I'm the other therapy, I'm the occupational therapist. They're going to help you walk and I'm going to help you get dressed because nobody wants to walk around naked. So it's sort of the funny way that I introduce it. But physical therapy is really focuses on physical function and how does your body move? How do you move? How do you transfer? What's your strength and your balance? And OT takes that and incorporates that into the activities that we do every day. They're called occupations. What do we do to fill our time? So it's not just our physical capabilities and how we do that. It's cognitively, how do we manage that? Do we have the visual scanning ability? Do we have the visual skills to be able to do what we want to do? In vision, one of the things I always talk about is, can you scan your environment and find the things that you need to find visually? And then we also look at our social emotional components of a patient and what's their social support look like and how does that impact their ability to engage? That's really relevant in my current job. So the term utilized most frequently is social determinants of health. So that's, your education, your social supports, your food access, all those sorts of components. And that actually drives 80% of your healthcare outcomes. So when I think about that in relationship to occupational therapy, that's really how we differ from most other areas of medicine, is we really have incorporated that into our profession and we incorporate that into our treatments. It's patient driven, holistic care really at the heart of what we do in every treatment session.
Thank you. I had a question for Aimil and Nikki, just working with neurological patients. I was wondering if there are like unique challenges that come along with this, especially in the OT field.
I think my favorite part of my favorite population to work with is the neurological patient, because you have no idea what you're walking into every day. And Aimil had talked about Rla Levels, which is a Ranchos Los Amigos scale, which is a level of alertness. And it can be from a 1, which is not alert at all the way up to, and they keep moving the upper end. I think it's an 8 or a 9 now. And as people have head injuries, strokes, that kind of thing, they merge through, they kind of evolve through this scale. And the 4-5 level is my personal favorite because it's the agitated, angry, but direct, able to do things phase. And I've had people throw iPads at me. I've helped people take showers and I've been pulled into the shower and drenched. And I think my favorite part about the neurological setting is just that it's so different for everybody. And it's just fun. I don't know if that answered the question, but that's what I love.
I have to kind of echo what Nikki said, that sort of the unpredictability of the Ranchos level 4 and 5. It feels like entering into chaos, and it's an opportunity to organize it, which is something that I have always enjoyed. The other thing that I really like about the neurologic population is that there's not really a system as it relates to function that's not impacted. So for me, I also, mystery is maybe not the right word, but trying to figure out what exactly is the underlying cause and what is preventing the connection from what the patient is trying to do to what, what's the barrier that's getting in the way? And is it attentional? Is it visual? Is it a combination of the two? Is it a sensory component and they're just really having a hard time regulating in the environment? So that's the part that I enjoy the most. And then once you have a patient who's had some successes, I think I see this even with the post-concussive population who are, outwardly still seeming very high functioning. When you can make a difference for that population set, it's really rewarding. I have patients say like, I never really felt like anyone heard me until you sat down and explained like what was happening with me visually, and that explained why I couldn't read and why I was having headaches all the time. And so it's very, very rewarding, and it's very challenging. So it's a part that I like.
Okay, great. So we'll do one more question, which is in the chat before moving on to the case study portion. So the last question is for all of you is, do you mostly treat adult patients or how often do you work with children or teens?
We don't, sorry, I was just going to say, we don't have pediatric OT in this panel. And that's probably on me that we didn't do that. Peds is a huge part of our field, and I can't really speak to it because I've never worked in it, but I think a handful of other folks have some experience in peds, and I think it's probably a good thing to bring up because it really is a huge part of OT.
Yeah, and I can speak to from an orthopedic standpoint, we do see anywhere from kids from 2 months old all the way up all through the whole. I mean, I can see a 2-year-old and I can see a 92-year-old within 2 hours of each other or whatever. I mean, it's a huge array. We actually see a lot of kids coming out of CAS who just need a splint for recess or things like that. They do some congenital things, but my expertise is mostly orthopedic. But I agree with Victoria, there's a whole side of pediatrics and sensory integration and development. We need one in Vermont, another one in Vermont through the hospital. It's a program that I would love to see expanded through our institution, but it's really important. I also wanted to say one really quick thing, and going back, in our hand department, we work directly with physical therapists. You can be a hand therapist and a physical therapist or an occupational therapist. In hand therapy, 85% are typically occupational therapists and 15 are physical therapists, but we work side to side. We can share patients. It gets a little tricky based on our licensures and how we document, but it does happen. So it's a fine line in this specialty area of PT and OT in that sense, but in the whole grand scheme of occupational therapy, there are big differences And I can say that because my husband's a PT, so.
Well, thank you so much. And I think we'll move on to the case study aspect for now. But if anyone has more questions they can think of, we'll be able to address them at the end during a final Q&A session.
Well, and
And so
Julian,
we'll
I
let the
just
four of
wanted,
you take it away.
oh, can I just say one thing? PEDS
Sure.
really is a very huge part of our profession. So if there are any people listening that really want to learn more about PEDS, I'll put my contact information in the chat box. I can put you in contact with some very skilled pediatric OTs, and I'm sure others here can as well. I know, Aimil, you just unmuted as well. Maybe there's a quick thing you want to say about that.
Yeah, so we actually see pediatric patients through home care. They're usually, we see a lot of kids after ski injuries or after surgeries. We see a lot of kids who have surgical repair of congenital issues when they come home. I've seen a couple of kids that are polytrauma or acute, really had acute injuries. So it's not a huge part of my caseload, but I do see kids pretty routinely.
Okay, thank you so much. And then the four of you now can speak on to the case study aspect of tonight's session.
Aimil, did you want to start with the acute care setting?
Sure, I can. I missed the session that you guys went over yesterday, so I didn't know the plan. So give me just a second to pull it up because I had just pulled my notes for the. So we had talked about, this is a case study that I had written relatively quickly, that about a young person who'd had a traumatic brain injury after a motor vehicle accident. They hit a patch of ice and their car had spun around, and then they'd hit a rock wall in the interstate. The person was seatbelted and had was brought into the acute care hospital via the ambulance, entered through the emergency room. They had surgery for an evacuation, so to relieve pressure on the brain, and then were sent to neurological ICU to get stabilized. From there, they so their primary diagnosis was left temporal subdural hematoma. She stabilized quickly in the neurological ICU and progressed to the medical floor with initial goals of pain management and medical management, as well as some initial therapies to evaluate her current functional status. She was noted to be a Rancho-Los level 4, so you already know Nikki and I like to work with her, emerging into 5, and she discharged to acute rehab. She was at that point, she was able to transfer with moderate assist ×1. So with the help from one person with the appropriate setup, she was able to wash her face, brush her teeth, and complete upper body dressing. She did have noted speech delay with decreased expressive language and need for additional time to process information. So that's acute care. So
Do you want me to go on to inpatient rehab? So at inpatient rehab, what we need to know that they can do is the person has to be at least an RLA 3-ish, hopefully 4 or higher, which means that they are paying attention to people, they're able to follow directions a little bit. And this lady was at a 4-5. So that means she was confused, she was agitated, she was alert, she could do motor activities, but it's not always purposeful, so it didn't always make sense. So when she came in, we need to know that she can do 3 hours of therapy a day, and that's where they will get PT, OT, and speech language pathology. When somebody has an injury on the left side of their brain, often it affects what's the language center, and they can't find their words or they can't really understand what you're saying. So that's part of what this person was probably dealing with. So when she comes in, the OT often works with people in the morning, and we start to do what we call ADLs, which is activities of daily living. So we work with her on dressing, bathing, feeding, brushing her hair, brushing her teeth, getting her getting her set up for the day. We work on the transfers for that. So getting in and out of bed, getting on and off the toilet, in and out of the shower. The speech and language pathology, speech language pathology will work on the speech and the swallowing. They will do some of the cognitive pieces, so some of the thinking skills, and then the OT will also do thinking skills, but in that functional context, which is kind of how we're a little different from the other pieces. So can you sequence putting the toothpaste on your toothbrush, putting the toothbrush in your mouth, brushing your teeth, spitting, all those pieces. We will look at vision. Often with these injuries, there is a deficit or an impairment. It's affected their visual skills. So either their eyes don't play together nicely, they might see double, things might be blurry, they don't have good depth perception, that kind of thing. With head injuries, we always need to watch for seizures. They will be on some medication at some times, but sometimes they're not, or sometimes they will still have seizures, and that's when we have to watch for. As we work with this young lady and we get her more independent, she's now dressing better, she's bathing better, we have to start thinking about, well, what's her discharge plan? So while she's on inpatient rehab, we kind of set the goals with what we know to be important. So it's doing your own dressing, doing your own bathing, doing your own grooming, getting in and out of bed, in and out of a car, all those things. And then figuring out where are you going and how are you going to get around that space? Do you need adaptive equipment? Do you need a bench? Do you need grab bars? Do you need a ramp because you're still in a wheelchair? Those kinds of things. And then we'll work with the family and the patient to make sure that we set up a safe space for that person to go home to. And then from there, when they're done, they'll go home and get home health therapy. Back to you, Aimil.
So, yeah. So when I typically on initial evaluation, there's really a lot of education for family, depending upon where the person is when they discharge from acute rehab. If there's the recommendation for 24-hour care, I really am spending time with the family to just say, who's providing that? Do you have a calendar? And then I spend a lot of time on education. I talk really a lot about what is the recovery process for a TBI? What does home health look like? What are the goals for that person, sort of short-term and long-term? So maybe initially the goals are to be able to get in the shower, but eventually they'd like to return to work and driving. And so we start to lay out what is the path from here. I do a lot of education, as Nikki said, on watching for seizure activity. I also spend a lot of time talking about the importance of sleep hygiene, which is really taking rest breaks throughout the day and trying to make sure the person's getting restorative sleep at night. That's really a healing time after a brain injury is downtime, and particularly sleep time. So that's sort of what my first couple of initial visits look like. I'm also looking at the home, how the home is set up, what modifications are going to be needed, either short-term or long-term, and how are we going to get those in place. So it's connection. A lot of times it's connection with lending closets and community funds to either build ramps or address thresholds in the house or make doorways wider. So that's initially what I'm looking at, along with pain management, really making sure that they're set up with comfortable positioning at home, in bed, that when they're moving through their environment and moving through their daily routines, that they've got places to sit and rest if they need to. I also look at, how cluttered is the home environment, because sometimes that's overstimulating. I do a pretty in-depth vision assessment. I modify the home based on that. So if someone's got some pretty significant visual issues, we start looking at simplifying the home environment visually. So maybe we reduce what is in cabinets and put it in a pantry so that there's less choices. We would sometimes look at contrast or doing physical modifications, or these things called bump dots for your microwave, so that if you're having a hard time tracking and finding the popcorn button or the start button, that will put a raised dot so you can just run your hand over it till you feel that. I will sometimes start a visual motor home program if I feel like the person's really ready for it, or I will carry over if that was something that was prescribed in inpatient, I'll carry that over at home. The other thing that I really start to look at in depth at home is doing a cognitive assessment. What's their attention like? What's their sequencing like? What processing, how is their processing and understanding of information? And how does that apply to the occupations that they're doing? So I'll look at sometimes doing different types of support. So I always when I have students at home health, I always talk about compensation versus remediation. And you always start with compensation. This is sort of my same approach to vision. You always start with compensation and you move to remediation. So compensation means I give you something to help you do it. Remediation is I try to start fixing the skill so that you can do it yourself. I talk about it like if you had a broken leg, I would not ask you to go run the Boston Marathon. I'm going to give you crutches first till the bone heals, and then we're going to progress to a point where you can walk, and then where you can run, and then we're going to train. And cognitive skills and visual skills aren't really any different. So a lot of home health is a lot of compensation initially. And then sometimes we start remediation before they transition to outpatient. My goal really at home health is to get them, once things are settled and safe in the home, is to get them to outpatient really kind of as soon as they can tolerate it, because that's sort of their gateway to sort of their next levels of support. Also, before that happens, we look at the Tbi Waiver program to see if they're eligible for that. That is a long-term care Medicaid program through the state of Vermont, which provides case management services and one-on-one services if they're needed for individuals with a brain injury, and helps with getting them out into the community and returning to, so it's like ongoing social support to get them sort of reintegrated back into the community. I also will sometimes set them up with a referral to the Vermont Brain Injury Association, Voc Rehab, VCIL, which is Vermont Center for Independent Living. And then I work quite a lot with the Vermont Assistive Technology Program. So those are a bunch of programs I really look at. I provide the family with a lot of education, and not everybody gets all of those programs, but sort of what does it make sense for this person to be connected with. And that's when I usually start transitioning them to outpatient.
So with patients who have had head injuries or multi-trauma, we do see them. We always ask if they are still receiving home health services, because from an insurance standpoint, we have to get permission to treat them. Usually it's just for a splint is all we can do, because they are still receiving care in the home. And then the therapist that is there does that kind of rehab. But if they have been discharged from home health and that they're independent in their home, and then they can get to therapy, being a friend, a spouse, transportation is not an issue. If this one case in particular, if we were to manage a wrist fracture, depending on when we would see that patient based on either the date of surgery or date of injury, how many weeks out they are is kind of how we determine bone healing and the range of motion that we want them to have for their everyday functional things that they need to do. Whether, again, bringing the patient into the evaluation. Do you live alone? How much help do you have? What do you need to do? Do you need to cook all your meals? Do you have kids you need to take care of? Work responsibilities that you're getting or wanting to get back to. So we address all of that in range of motion. Pain levels we manage, scarring if there was a surgery, we manage swelling, hopefully. Actually sometimes we do see them pretty acutely because they're coming out of a cast, they need a splint. Maybe they're not ready for our outpatient services, but we try to help manage swelling on that end. and then just getting them back to even some strengthening. But the biggest push for that population is just function, getting them back to be able to, like the whole theme, can you get yourself dressed? Can you prepare your meals? How are you doing living alone? What is difficult for you? And kind of bringing them into what is needed and helping them with the goals they want to achieve. So we're sort of the end of the line, which is kind of a good thing. Usually they're walking either with or without canes, walkers. Sometimes they're still in a wheelchair. I mean, we see huge changes from when they walk in and then when they're discharged. So that's exciting to see in the whole continuum.
And then this is kind of the last bulk of therapy that people can get, which is good and bad, because we feel like the last line, which, yeah, you made it, but if they're not back to 100%, it feels hard. But in the neurological setting, we work with people to get to the things that they want to do. And all the other places that I've worked, like inpatient rehab and all the other ones, I kind of know what they need to do. I know what they have to be able to do when they go home. Here, they tell me what's important to them. What do they like to do? What do they want to do? What do they have to do? What's left? We talk about going back to work. We talk about going back to driving, leisure activities they want to do. We take a last look at all the ongoing visual issues, cognitive issues. Like Aimil was saying, do we fix it or do we try and give them strategies to work around it? And try and make them as functionally independent as possible so that they can go on and do the things that are important to them. We give them referrals to other supporting clinicians or providers. If they have more vision problems, we find optometrists or ophthalmologists that will help them. There's Voc Rehab who will help them with jobs. There's other people, there are all sorts of different services, and we connect them to the services they need. And like all the other places, we watch for seizures just to make sure. One of the big things about returning to driving in the state of Vermont is you have to be seizure-free for 6 months. So if they are going to driving, I need to know that, yes, they have been seizure-free and they are ready to go to maybe a driver rehab program, which is another OT site that we have at the Fanny Allen campus to help them safely transition back to those things. But that's kind of the spectrum of care for someone in this position.
So the last slide that we have here actually is the curriculum here for the OT program here at UVM. And we wanted to put this in as kind of the last slide because the case that you heard about, and you heard about all the different levels of how this person would be seen, you know, across the entire continuum of care, that type of a case would have landed in this curriculum in that 5th semester. The fall of the 2nd year. And the entire case that you guys kind of listen to here is exactly the type of stuff that happens in some of these very large experiential classes that we have. In the spring semester of the 1st year, it's a 6-credit course on older adults. In the fall of the 2nd year, it's a 6-credit course on young adults. That's really where we handle a lot of the neurological rehab concepts that were discussed today. And in the spring of the 2nd year, that's a 6-credit course where the students will look at cases related to children. And that's kind of our pediatric semester. So what I wanted people to see is that we take students in these large courses through these cases, exactly kind of like you heard about today. But aspects of those cases are addressed already in that 1st semester. That's where the students are going to have functional anatomy. They're going to have a movement course. They're going to have activity analysis where you're going to really break down activities like we've talked about. That's where there's going to be a psychosocial and mental health course as well. And then in the spring semester, that's where the neuroscience, the visual, cognitive, perceptual courses are happening. In the therapeutic interventions course, that's where the students are going to learn to splint. So there's aspects of that case that start in the very 1st semester, but then in these larger classes, these big 6-credit courses that we have, those are really our experiential learning classes where our goal is to take the students through these cases and take them out into the community to where they're actually seeing and working with clinicians doing exactly some of the stuff that you guys heard about today. The other thing I wanted to point out on the curriculum is we all talked about our field work. And so if you look at the curriculum and you look at summer, those are the 2 semesters, those are the 2 semesters where the students, where you guys will be going out and you'll be some of you might be here in Vermont, but a lot of you may be all around the country. And this is where you'll be working side by side with an occupational therapist. And then the other part of our program that is pretty cool is this whole idea of a capstone project and a capstone experience. And so what students will be doing is they will be looking to kind of create like an individualized part of their OT education. And some of the students are going to come in and they're going to know exactly what they want to do. Some students are going to come in and they're not going to have any idea what they want to do. Either scenario is perfectly fine, because what we're going to be doing is we're going to be working with folks to see, what are you really interested in trying to like learn a little more about? For some people, it might be research. They may say, you know what, I really want to be a researcher at some point, so I'd really like to focus on research. Other people may say, you know, I'm really interested in some of this visual rehab stuff that I heard Nikki talking about. And I'd really like to go work with someone who, for, you know, a semester who's really an expert on this, so that when I leave the OT program, I feel as though I have this additional skill set underneath me. Or some folks may say, you know what, I'm super, super interested in hand rehab. I'd really like to really specialize in that. And I'd like to develop my capstone experience in that field. Some people may decide they want to do advocacy, and they may go down to Washington, D.C. and decide to work with our national organization and some of the legislators on the Hill and try to influence policy. You can really do what you want to do. And I think that's a really neat and exciting thing about the program, is that in your very last semester, in that spring of the 3rd year, you're not with us. You're somewhere where you want to be. And that might be that you are in a research lab. It might be that you're down in Washington, D.C. It might be that you're at an SI clinic somewhere out in California, or who knows, you know, that's kind of cool. I actually have no clue where folks are going to end up, but it's a really neat part of the program. So the reason I wanted to just put the curriculum up here at the end is so that people can see how everything that you heard about today really is embedded within our curriculum in some different capacity. And that's kind of where we thought we would, how we would wrap this up. And
Thank
I guess
you so much. And it sounds like, yes. And I had just a final question that I really love asking our panelists. I mean, I know you all don't work directly at UVM Medical Center, but what is your favorite part about being an occupational therapist with the Vermont population?
I'll start that. I didn't grow up here. I grew up in Montreal, in a very urban area. I think my favorite thing about being in Vermont is people are very resourceful and community-based, and they will do anything they can to either help people who've been in their community that had an issue, or to make themselves as functionally independent. And the things, I've worked with so many farmers that are the most resilient people. So I think I learn more from people here by their resilience and their community sense.
I would say the population in Vermont, the people that I treat are so active, even, you know, at much older ages. It's shocking how independent people are, you know, 70s, 80s, 90s, and they're out there skiing, hiking, they're walking with their dogs. I mean, it's really cool to see that the love of the outdoors is throughout the whole community. And we see these patients living their lives way into their, as they say, as long as I can walk, I'm going to be outside every day. I mean, it's so great to, they love to be outside, and I appreciate that.
I absolutely love Vermonters' autonomy. They are people that have lived here for a really long time, they're, as Nikki said, so much more resourceful than than when I worked in Maine or when I've observed other places. Most of the time I just tell people that I'm like a consultant. Their job is to tell me what their problems are, and I'm going to help them problem solve a way to solve them. And that most of the time it's really just sort of me guiding them through their own problem solving. So I really enjoy that. I've learned a tremendous amount from my patients here. And it is, the sense of community is incredible. When you work home care, everybody knows your car. And they'll say things like, well, we know you can't tell us, but when you go to Mrs. Smith's house later, would you let her know that we're going to drop off dinner on Thursday night? I'm just like, okay. To just sort of, you're really embedded in people's lives when you work and treat in Vermont, and it is really wonderful.
One thing for me that I am pretty excited about, it's coming a little bit more from this research angle, but it does link in, is this overall desire. It kind of tags along with what Jen was saying a little bit about just activity, health, and wellness, and that it's kind of embedded within the culture of the state and of the individuals in the state. And one of the things that we're starting to work on, I'm working on this with one of the PTs at UVM, is looking at our two professions, the allied health professions of PT and OT, and how do our professions really contribute to overall health and wellness when you're just working with individuals that maybe don't have an injury per se, but they're not necessarily engaging in life the way that they want to engage, but they're not totally sure why they're not either, because nothing major is really going on. And we're starting to kind of explore this, and I'm excited because it's, we live in a state where these concepts and ideas that are a little out there are embraced for us to explore, to see, if we're looking at our two allied health professions from a preventative care perspective, do we see changes in some of these health metrics like Aimil was talking about in terms of social determinants of health and overall health markers? So it's a little bit of a different twist on the question, but that's what excites me, is the fact that we live in a place where these concepts are embraced in terms of yeah, let's explore it and see what happens. So.
Well, thank you again to our 4 wonderful panelists. Oh, sorry. I don't know if someone was trying to say something. I missed that.
Go ahead, Will.
Oh, I just want to thank our panelists again for a wonderful session. It was really incredible to learn about occupational therapy. And I want to just preview our December session, which will be featuring a panelist of pharmacists, which will be really exciting. So join us on December 16th. It's the third Thursday to help with the holiday season, and it will be again from 7 p.m. to 8:30. So we're looking forward to seeing you all next month, and thank you again to these wonderful ladies.
Thank you.